Welcome to the seventh installment of Honors College Forum Pandemic. I'm Dean Linda Kuhn of the Honors College, and it's my great privilege to introduce to you my decanal colleague, Dean Brian Primack of the College of Education and Health Professions. Brian is a super impressive academic. Before he moved to Arkansas to take up the deanship, he was a professor of medicine, pediatrics, and clinical and translational science at the University of Pittsburgh School of Medicine. He also served at the University of Pittsburgh, or Pitt as we call it, as Assistant Vice Chancellor for Research on Health and Society and the Leo H. Kripe Endowed Chair in Patient Care. He was also the founding director of the University of Pittsburgh's super famous Multidisciplinary Center for Research on Media, Technology, and Health, which is widely regarded as the most influential center of its kind globally. The center has over 200 publications in the past decade, over 10 million in federal research funding, and multiple top research awards. Its findings have been published in multiple major journals in medicine, public health, and social science, and those results have been reported in news sources such as NPR, New York Times, Cosmopolitan Magazine, US News and World Report, the BBC, etc. In terms of research, Dr. Primack combines his expertise in education, technology, human development, and medicine by researching both positive and negative effects of media messages on health. He is a pioneer on the use of media literacy education in preventing adolescent smoking, underage drinking, and other harmful adolescent health behaviors. Dr. Primack has also conducted extensive research on various forms of tobacco and nicotine use, including traditional cigarette smoking. Last year, Dr. Primack was the seventh person in the state of Arkansas to be elected into the American Society of Clinical Investigation, the leading organization globally for physician scientists. But I like to say, best of all, Dr. Primack was Dean of the Honors College at Pitt. Woo! So I'm going to turn the forum over, over to my colleague, my honors colleague, Dr. Brian Primack. And remember, let's keep everybody muted and don't mess around with your computer too much. So, Dr. Primack.
Well, thank you so much, Dean Kuhn, for that very kind introduction. And I'd like to thank you for your leadership in creating this course. It has been really remarkable. And I've also really appreciated working with Associate Dean Pop on the development and implementation of this course. It's just been very impressive what you guys have been doing. I'd also like to thank Louise for helping me with all of the technical aspects. And with that, let's go ahead and dive in. I am going to be talking about the public health perspective on this pandemic. And you'll be probably a little bit surprised that it might not be exactly what you think of. I am going to start, though, and frame everything with this very provocative question: how many people are going to die? But we're going to quickly see how that question starts taking us in many different detours and thinking like public health people. So I'm going to start off with just a little bit about the name. As you've probably heard of the coronavirus that we are calling COVID-19 as the novel coronavirus. The reason for that is that in medical school, now 25 years ago, I learned that coronavirus was one of the many causes of the common cold. And in fact, as you can see here, it's sort of one of the more common ones. The one that we have today is novel in that it's just slightly different. And that's why it's able to do different things in terms of being more deadly and being more problematic in other ways. Why is it called coronavirus? Some of you may know, but you can see these little spikes on it. They almost look like little crowns. And the word corona in Latin is crown. That's why the corona of the sun, it looks like sort of a little crown around the sun. And Corona beer was using that as sort of the king of beers, the way Budweiser does. So when we start to think about how many people are going to die, we can look at all kinds of models. And I know that you guys have studied before, and you've all seen the Johns Hopkins splash page that talks about how many people have died in the world, and you can break it down by different countries and that type of thing. And so we're looking at, around 250,000 from COVID-19 as of now. The estimates are anywhere between, say, 500,000 and 1 million when this phase of this virus is done, quote unquote, although we'll be coming back more to that idea. So this is one way that we can start thinking about those deaths. Here's another model that you may have seen. This is the University of Washington data, and you can see here that they're showing about how many deaths per day there have been, and you can see that they've actually been pretty accurate in their overall guesses. The shaded area here is the 95% confidence interval. So this is all projected because I took this screenshot, a week and a half ago or so. The other thing that you can find on this webpage that the University of Washington puts up is these different estimates of the number of beds that are needed. This is the purple dashed line that would be needed for people who have coronavirus. The green is how many ICU beds would be needed, and the blue is how many ventilators would be needed. And the reason that the green and blue lines here are so close together is because in a hospital, if you go into the intensive care unit, it's almost always because you need a ventilator. And so overall, this model projects that, this line is the number of total deaths, that will end up somewhere around 72,433. That number changes every day based on what has happened before. One major story is that this has been extremely different in different parts of the United States. So we know that New York has been heavy hit. And what we can see here is that New York has this purple line of hospital beds available, but guess what? They needed a lot more beds than that. And so this is why we saw such terrible things go on there, and some unnecessary morbidity or mortality, morbidity just being the fancy word for disease. And then you can see the same thing here. This green line represents the number of ICU beds available, and New York just plowed right through that. They needed a lot more ICU beds. They needed a lot more ventilators than they had. And that is what caused a lot of their problems. And so ultimately, this was their curve, and they're projected to have about 24,000 deaths. You can see Italy here. Italy did not go through its number of beds available, but it plunged through its number of ICU beds available, which was the problem there. This is Italy's curve. You can see that there was a big and dangerous and problematic spike that was followed by a little bit more of a linear downtrend. And it's completely different in Arkansas, where you can see that our deaths literally per day are somewhere in the 2 to 3 range. And if you look at how, we've been faring, you can see the purple line. Well, our purple line down here, the number of beds that we need is nowhere near this. And then similarly, we have this number of ICU beds, and the green line is so low that you can barely see it. So things have been very, very different in different parts of the country, and we're only expected to have a total of about 150 deaths in the state. One thing that's going to be very interesting, of course, people are talking about a lot these days, is reopening. Nobody really knows what the optimal balance is going to be in terms of reopening society. As we are going to learn over the course of the next hour and 15 minutes, there are a lot of risks of keeping society closed, psychologically, economically, physically. But of course, there are a lot of risks of opening up too quickly. And so one thing that we can do is look to historic data. And you may have seen this graph before. If not, this is an example from the 1918 flu pandemic. And that killed, by the way, worldwide, 50 million people. And at that time in history, you know, 100 years ago, that was a much bigger percentage of the world population. But what this graph shows is Philadelphia was a city that decided to reopen quickly, and then they ended up having a second major spike, whereas St. Louis was a city excuse me, that decided to open up more slowly, and they had a much lower death rate, you know, after that. And so this is one thing that people have been discussing. Okay, now that we've talked a little bit about death numbers just related to COVID itself, we've been talking about maybe a worldwide toll of somewhere around, 500,000 to maybe 700,000. It's maybe 250 right now. We're talking about a United States toll of around, 75,000. It's interesting as a public health person to think globally and to think not just in terms of the morbidity and mortality of one thing that's happening, but of everything that's happening. And so that's why, for example, this article caught my eye. You can see that this was reported, a month and a half ago by CNN. And what they did was they showed this picture of, January 1st, 2020. But then in February, late February 2020, after China was locked down, look at the difference in nitrogen dioxide, which is a very common pollutant. So you can see, terrible pollution in China, but then you can see that pollution is gone. And what this researcher said, sort of very provocatively, was that this coronavirus lockdown actually may have saved a lot of lives because of pollution. Okay, so let's look at this a little bit more. Here is a little bit more of just looking at Wuhan, looking at 2019 pollution and 2020 pollution. And you can see that these are the more dangerous levels, the red in terms of nitrogen dioxide, and that the blue is almost none, or very, much less dangerous levels of nitrogen dioxide. The person who wrote this article was a professor of earth science at Stanford University. And what he estimates, I will just sort of summarize, is that the deaths in China during January and February were about 3,500 people. And even though people question the numbers overall, if we can trust the numbers, their death toll really hasn't gone above 4,000 or so, or it's been about that. But what he says, quote unquote, 2 months of pollution reduction has likely saved the lives of 4,000 kids under 5 and 73,000 adults over 70 in China alone during those 2 months alone. Why children under 5 and adults over 70? Well, those are the populations that are most at risk for pollution death. And what he did was he said he kept estimates conservative by assuming that nobody between 5 and 70 died from pollution, even though some probably did. And so he's saying that around the net lives saved in China, at least during this period of time, was around 73,000. Now, none of this is to say that pandemics are a good thing. As we're going to see later on, this pandemic and pandemics in general cause, huge amounts of other problems that we'll be discussing. But this is just one example of how a public health person thinks very broadly about what is going on. So you might say to yourself, well, how do you even figure out how much death is related to something like pollution. When someone comes into the emergency room and is and the doctor says to the family, "I'm so sorry, there's nothing we can do." They never say it was pollution, right? So how do we figure this out? Well, this is how we figure it out. We do studies that, for example, look at just one pollutant. This stands for particulate matter that is less than 2.5 microns in size. So what's a micron? Well, each one of these lines is a micron. It's the same thing as 1 micrometer. So you can see here 1, 2, 3, 4, 5 micrometers. A red blood cell or an erythrocyte is about 6 or 7 microns. A bacteria, E. coli, for example, is about 1.5 microns. A virus like HIV, coronavirus also, is about 1/10 of one of these. And then a white blood cell, as you can see, is much bigger. So particulate matter that is less than 2.5 microns is like half the size of that red blood cell. What they did in this particular study to try to estimate how much death pollution was actually causing is they looked at 4.5 million people over a period of 10 years, starting when they were 64 years old. And over those 10 years, they found that 36.4 people, around 1.6 million people died, about 1/3 of the people in the study. And what they did was they estimated how much of that 1.6 million was from PM 2.5, and they estimated that it was about 200,000. And I'll explain how they did that in just a moment. So what this would mean is that around 12% of all deaths of these people who, on their death certificate, it says heart attack, or it says, lung disease, or it says pneumonia or something like that. But that actually around 12% of those deaths were from this particular kind of particulate matter. Now, how did they do this? Well, what they did was they looked at places where the quartile of PM 2.5 was really, really high. So this might be data from Los Angeles. Number 3 might be data from Cincinnati metropolitan area. Number 2 might be a smaller place like Kingston, New York. Number 1 might be a place like, like Siloam Springs, Arkansas. And what they found was that even when you control for all the other factors, like age and sex and how sick people were, and what kind of health insurance they had, et cetera, that the people who lived around more pollution in a linear way, they died more frequently. And so what epidemiologists are able to do is crunch the numbers and say, guess what? This number of people, in this case, around 12% of death was attributed to pollution. Okay, so let's look at all of these other cases of death. This is what they said in this article, is that things that, really were because of particulate matter was about 56,000 people from heart disease. This is among, remember, this very large population in, this one VA study, which is the Veterans Health System. Around 40,000 from stroke, around 7,100 from kidney disease, et cetera, et cetera, et cetera. And then if you add in a few more deaths from other reasons, these are just the top ones, it was about 200,000 that were attributed to PM 2.5. So all of this has led to, interestingly, even just during this time, a lot of people saying, gosh, you know what, the world is actually facing a pandemic, maybe even more dangerous than most viruses, air pollution. So what they said, for example, here is that according to the World Health Organization, air pollution might have caused around 9 million premature deaths in 2015. In general, it might have actually shaved off an average of 3 years from life expectancy. And you might say to yourself, well, a lot of the people who are dying of these reasons, were, older, they had secondary, they had pre-existing conditions, they may have died within the next year or two anyway. But that's also, of course, what we are seeing with the coronavirus. Another thing that's kind of interesting is this study showed that in places where there's more pollution, COVID is more likely to kill people. And in general, what they're estimating is that it's about a 15% increase. In other words, if you come down with COVID and if two people are twins, they have exactly the same, pre-existing conditions, they're exactly the same age, they have exactly the same diet and exercise patterns, they have exactly the same smoking status, etc. But one lives in a more polluted area and one lives in a less polluted area. The person in the more polluted area is 15% more likely to die from their COVID case, whereas the person in the less polluted area very well might live even though they had COVID, but they were just more likely to get through it. Okay, so all of this leads to, what are the kind of top causes of death in the world? Because we've been talking about a lot of these. Well, if we look at overall causes of death, this is normally what you're going to see. You're going to see heart attacks, stroke. You're going to see chronic obstructive pulmonary disease, which is another word for emphysema, which is what smokers get. You're going to see pneumonia, Alzheimer's disease, et cetera, some cancers. And you can see that these red lines are more like communicable diseases. The blue ones are the non-communicable. And the reason that we do this is that it's extremely different in low income. Take the look at the low income chart. They're almost all red, infections of various kinds, malaria, tuberculosis. Whereas things like heart attacks and stroke, people just don't even necessarily make it to that old. But in the developed world, it's almost all the blue causes. It is, top causes of death in upper middle income countries in 2016. And by the way, some of you might say, well, gosh, why aren't we seeing more cancer here? We are seeing liver cancer and stomach cancer, and we are seeing lung cancer. Well, a lot of times cancers get coded as other things. So this is another, thing that we need to do whenever we look at data like this, is say, well, was that really due to this underlying thing? Bottom line is that if we look at the top causes of death in the world, we always need to think of the world as really being two major things: the low income countries and the upper and middle income countries. Very, very different. So a very, very different public health approach. Okay, this all leads to this idea of loneliness, psychology, depression, anxiety. Vivek Murthy was the previous Surgeon General of the United States of America. So sort of like the top doctor. And he wrote this article just before all of COVID and said, you know what, we are in this loneliness epidemic, and that reducing isolation at work is really, really important. We need people to be more connected. But of course, what are we doing in today's world? Because of this pandemic, we are isolating people more. in fact, the term that is being used is we need to socially distance people, which sort of implies social almost isolation at its extreme. Now, a more correct term, and the one that we should all be using, is physical distancing, because we don't want to socially distance. We somehow want to physically distance so that we are not passing germs to each other, but we somehow need to still stay socially connected. So it's a linguistic thing, but it's a potentially important linguistic thing that I figured I would at least just mention. And public health people kind of shake their head whenever somebody says, we are doing social distancing. It really should be physical distancing. And one of the reasons that we believe that is that we have seen studies like this. If you think that pollution is a problem, just think about depression, anxiety, and loneliness. And you can see, headlines like this: loneliness is a strong predictor of premature death. Here is an example of a study that is often cited from 2015. And what they did was they basically did a meta-analysis, which means they took all published literature in this area and they somehow crunched it all together. These are very complex to do, but very, very cool and interesting. And what they found overall, when they looked at mortality as the endpoint, so they're not just looking at, are you going to get, a cold? Are you going to get pneumonia? Are you going to get sick? It's, are you going to die? And what they found was that the odds ratios were 29% higher, 26% higher, and 32% higher for mortality if you felt socially isolated, 29%, if you felt lonely, 26%, and if you lived alone, 32%. What this means is that, again, if you take those twins who are exactly the same, if one of them is feeling connected and not lonely, and they live with other people, and the second person has exactly the same risk factors for, death and things like that, they have the same smoking status, they have the same diet and exercise patterns, they're about 30% more likely to die. So all of the things, and a lot of you asked questions that I think were very, very good questions, because you said, well, wait a second, isn't there sort of an epidemic of depression and anxiety and loneliness that's also going on? And that's not just going on among the people who have COVID, that is going on among everybody. Now, again, it doesn't mean that it's not absolutely tragic what's going on for people with COVID. It's just that as public health people, we need to think of the suffering of everybody. We need to think of the suffering of that person who has COVID, the family member of the person who has COVID, but we also need to think of, those things that we're not necessarily thinking about, the people who are actually going to be dying from being more lonely and more isolated, and the people who are going to potentially not die because there was less pollution because, of lockdowns. Here is another example of a study that showed that loneliness was associated with all outcome measures. And look at this. Lonely people compared with not lonely people were twice as likely to decline in their activities of daily living. In other words, not being able to feed themselves, not being able to clothe themselves, etc. Kind of makes sense, but still very interesting to see in black and white. They were more likely to develop difficulty with upper extremity tasks, but most critical, it was associated with an increased risk of death, where the people who were lonely were about 50% more likely to die. And this is just a different study. The bottom line is that this is something that is very, very big in public health right now. Another thing that we need to think about, of course, is age. We've seen that, and I mentioned this before, that people who are older are more likely to be dying from COVID. These are data right here that you're looking at from the United States of America, Centers for Disease Control. Here are data from the Chinese Center for Disease Control and Prevention. As you can see, they're quite similar. There might be a little bit of a sharper peak here, but that could be an artifact as well. However, when we come back to this idea of mental health, we actually see that recently mental health, neuropsychiatric disorders became the #1 cause of DALYs, disability adjusted life years. So it's not just deaths from feeling depressed, anxious, lonely that we have demonstrated in the literature. It's also more disability. These days, the World Health Organization, that's the WHO down here, the World Health Organization estimates that more people are disabled because of mental health problems than because of, say, back pain, which is what #4 is here, musculoskeletal disorders, or having such bad chest pain that you can't go into the, to work, or, that kind of thing. If you look at it with a different outcome, this is, this is very similar to DALYs, but it's, years lost for disabilities. Then again, mental health problems are now #1 over what we had seen before was back pain. So all of this is to give us perspective. For whatever reason, China seems to have had a very, mild course of this condition. It may be because the data aren't perfect. But if we do trust the data, the Brookings Institution, a major think tank, says this is how many people died, from stroke in China. This is how many people died from COVID in China. Again, as public health people, we need to think of all the big causes of death. And guess what? Motor vehicle collisions are not a small cause of death. So you can see, there's a lot of motor vehicle accidents, and you can see that they go down and up with the seasons, which is kind of interesting. But you can see that on average, around 16 to 18,000 motor vehicle accidents, and all of a sudden, there's a reduction of like more than 75%. The reason that this is not small is that 1.3 million people die every year from car accidents. That's a lot of people. And so let's say that because COVID made less people drive, that number even goes down by just 10%. I mean, here we're seeing that the number of collisions is going down by 75%, but that's in New York City, where, there's a particular risk of collisions, let's say it's only 10%. That would mean that 135,000 people are not dying. Here is another image of traffic in a city in Italy, and you can see this red line represents when the national lockdown was. And so you can see that with these reductions in traffic, we're going to be cutting in more and more to that 1.35 million people that generally die from traffic accidents. Again, it's never a good idea to have a pandemic, and none of this is to say that there's anything good about the pandemic. It's just to say that public health people are thinking about all angles. Okay, so let's sum up a little bit. We've seen overall that these are some of the top causes of death in the United States. When we look at, those cancer deaths and we kind of add them all up, it's kind of #2 to heart disease. Accidents is quite high. Chronic lower respiratory diseases is pneumonia. Stroke is when, blood doesn't get to your brain, Heart disease is like a heart attack. Blood doesn't get to your heart, so your heart can't beat right. Stroke is kind of the same thing, where blood just can't get to your brain right, and so part of your brain dies, et cetera, et cetera. But again, we need to think less about the ultimate condition and more about what's underlying it. In other words, why do people get heart disease in the first place? Well, the number one reason that people get heart problems, if you crunch the numbers, sort of like we did with that pollution study, is actually tobacco. But guess what? Cancer deaths are also often tobacco. Lung cancer is 11 times more common in someone who's smoked versus someone who hasn't smoked. So a lot of these 600,000 deaths every year are actually because of smoking as an underlying thing. And also a lot of these heart disease ones. Now, of the accidents, pretty much none of these are because of smoking. But because of pneumonia, a lot of these are because of smoking. Because of stroke, a lot of these are because of smoking, because smoking damages blood vessels, which is why it can cause a lot of heart disease and a lot of stroke. And so when you look at the underlying annual deaths in the United States, this is what you get. The tobacco is still, even though it seems like fewer and fewer people are smoking, the rate of tobacco use is still around 20% in the United States. But it is the leading cause, underlying cause of annual deaths. And that number worldwide is 5 million. Now, you might say to yourself, what's going to happen because of the number one cause of death in the United States and the world? That 5 million is also the number one cause of preventable death in the world. What is going to happen to tobacco use because of COVID? Well, a lot of people are saying that, when you have more depression and more anxiety, that you're more likely to relapse if you ever quit. You're more likely to start smoking if you're home and you're bored. On the other hand, you might say, well, maybe you couldn't get cigarettes as easily, and so maybe you somehow quit. That is seeming to be less of the pattern. The pattern, in at least at this point, it hasn't really been able to be studied in a very rigorous way. But at this point, it looks like the annual deaths from tobacco are going to increase significantly. And if you think of the worldwide toll of tobacco being about 5 million deaths per year, if that increases by, say, 4% this year, that would be another 200,000 deaths. What about diet and activity patterns? I mean, that's the number two cause of underlying disease, because if you look at things like heart attacks, it's because people have poor diet and exercise. Some cancers are related to diet and exercise problems. So this is the estimate as to what the number of deaths is because of diet and activity patterns. You may have noticed that people are biking all over the place. It's impossible to find a bike at a bike store in Northwest Arkansas these days, because everybody is starting to take up, things that they can do around their house, around their neighborhood, because they're not commuting and that type of thing. On the other hand, a lot of people are eating worse. On the other hand, some people are eating better because they're not eating out. And when you eat out, there's a lot more oil in food, there's a lot more salt in food, and that kind of thing. Then let's go ahead and go one level beyond. Will these things, if they change in some way, will they be sustained beyond COVID? If we assume that in the next year or two, somehow this is going to get sorted out and there'll be a vaccine, and an extra 10% of people, the rate of smoking goes up from, increases 10% from 20% to 22%. after COVID, is it going to go back down? Almost certainly not, because of how incredibly addictive nicotine is. It is one of the most addictive chemicals that has ever been, shown to humans. In fact, when they do studies with mice, they're actually able to show that in some ways, nicotine is more addictive than heroin and cocaine, because they'll hook up mice so that they can press little levers and get, different drugs put right into their brain. And what they'll do is they'll find that, the mouse that is in a room with just cocaine, it likes the cocaine, it'll have some cocaine now and then, but then it'll go eat, then it'll go back and have a little more cocaine, and it'll go eat, but the mouse that's in a room with just nicotine, it'll just give itself nicotine until it dies. So this is the way that people can do studies to say, once someone has been addicted to nicotine, this is why it's so incredibly difficult to stop. Whereas diet and activity patterns are almost certainly going to go back to what they were. In other words, as soon as restaurants start opening up, and especially after there's a vaccine and people feel safe in restaurants and things like that, and people feel protected, then they're almost certainly going to go back to eating in restaurants about the same as they did before. It might be a little bit different, but this, again, is the kind of behavioral science linked to the epidemiology that we think about in public health. Okay, a lot of people compare COVID to flu, and it is true that flu kills a lot of people. And for example, here was a bad flu year and 61,000 Americans died. In a not so bad flu year, a couple years before that, only 23,000 died. If we're looking at 72,000 for COVID, you might say, oh, it's not that much more. But first of all, it might be a lot higher. We really don't know at this point. And it was a lot faster. So you can see the way flu deaths kind of, they're a little bit, they definitely are seasonal, but they are more spread out. And so the healthcare system is able to deal with them. COVID is certainly causing more deaths and more problems in a shorter amount of time for various different reasons. There's been a lot of talk about different countries and how different countries are handling this crisis. And South Korea is an example of a country that is winning the fight, quote unquote, against COVID. And a lot of this is, because of testing, which we're going to talk about in just a moment. A lot of this is because of, very strict control measures. There have been people that have said certain Asian countries may not have been affected as much because they're bowing cultures. And so you don't shake hands as much. And shaking hands was such a common way that the initial, epidemic was spread. I mean, that has never been proven, but this is just something that people have been saying. But I think it's important to look at overall death rates when it comes to something like COVID and to really think about this for a second. I mean, is Italy really just, people are just sicker there, like their COVID is just worse? I mean, if you're talking about 8% death versus Switzerland, Italy and Switzerland are like right next to each other. I mean, and yes, they're different countries. They have slightly different systems, but I mean, is it really 8 times more deadly in Italy versus Switzerland? And, Switzerland versus Norway, is it really 5 times as more deadly in Switzerland than Norway? The answer is no. The answer is that this kind of thing is almost certainly because of the denominator. Who is being tested? Italy, because they got the condition early, tests were not really that available. And so what happened was they were just testing people who were already very, very sick. And so it kind of makes sense that if you're only testing, a 100 people that are really, really sick, yeah, 8 of those people, might die. Whereas in Switzerland, you weren't just testing those 100 people who were really sick, you were also testing 700 other people, okay, who were maybe not symptomatic. And so then what you ended up with was 800 people, 8 deaths, a 1% death rate. So very, very important anytime you see death rates, anytime you see anything, to think about, well, exactly who is getting tested, how many people are in that denominator. Okay, let's use this as an opportunity to start talking about testing. So the way you test for the virus itself is called a PCR, or a polymerase chain reaction. Basically, it's a way of taking the actual DNA from the virus and multiplying it enough so that you can detect it. It hurts. Usually you have to take a nasopharyngeal swab and really touch the back of the nasopharynx. A lot of people don't do this correctly, and so these tests sometimes are not very accurate. The other thing is that they're very expensive, which we'll see in a moment, and they're not necessarily as available. They are becoming more available over time, but this has always been an issue. Okay, I mentioned expensive. Someone sent me this, and so I had to take out any identifying information. This was somebody who on March 24th went into the hospital for potential COVID. Their cost for being in the emergency room was $1,766. Their X-rays and CT scan of their lungs was $669, and their laboratory services, which apparently was mostly just the COVID test, was over $2,000. So this introduces the whole idea of healthcare economics, which is another whole field of public health, by the way. There is an entire field of public health. We've been talking a lot about epidemiology, a lot about statistics, and a lot about behavioral science. But there's also this whole field of health policy and management that includes all of this health economics. This is the kind of stuff that public health people study. How does this happen, and why does it happen, and what can we do about this? Okay, let me now talk about the other tests that people are talking about, because they're very, very different. Whether you're actually looking for the PCR, remember, we were looking for the critter itself, the actual COVID DNA. But for an antibody test, you're looking for an antibody that you have produced against this COVID virus. And what that would mean is that we're looking for this protein. You made it in response to COVID. And so presumably what that means is you have been infected in the past. Now, what that may mean is that you may be immune because you've created a molecule that knows how to attack it. However, we don't know how immune you are. In other words, there are some conditions where you'll make antibodies and then you'll be able to kill it whenever it comes back. But there are other conditions where you make antibodies and sometimes you're able to kill it, but sometimes it comes back and still overwhelms your system. So we don't know how immune you are, even if you do test positive for antibodies. We also don't know how long it's going to last. You probably know from getting lots of vaccines when you're a kid, or if you're a parent and you see your kids get vaccines, that sometimes the doctor will say, this vaccine lasts your entire life. You only need yellow fever vaccine once. Other times they'll say you're going to need this, you're going to need a booster in 10 years. And then other times, like the flu, they'll say you need this every single year. So we really just have not had time to figure it out. So even though people are talking a lot about antibody tests, a public health person has to say, well, wait a second, what is the antibody test really going to tell me? There are 70 different developers working on different kinds of antibody tests. These companies have emergency authorization to start testing. Normally, they would not be allowed to even start without doing a lot of other studies. But basically, it's the Wild West out there. And so these tests are poorly validated. What do antibodies do? Well, the reason that they're in this kind of shape here is that this variable area is going to stick to, you see this orange piece, the antibody is going to stick to this cancer cell. And when it sticks there, it's going to send out signals to the rest of the blood and say, hey, help me kill this cell. Okay, so this is how antibodies work. But what's the quality? What's the quality of the antibody test? I mean, we talked about the fact that we don't really necessarily know if you're positive or if you're negative, what that really means. But there's also problems about whether the test is actually going to get positive or negative right. A false positive means that you got a positive, right? That's why it's a false positive. But it's false because you think you have an antibody, but you actually don't. So when somebody gets a false positive, they're like, yay, I am immune, party. I'm not going to have any problems. But guess what? This person actually is not immune. And so that can cause problems. And then there's the idea of a false negative. You think that you don't have antibodies, but you actually do have them. In this case, that might be a little bit less problematic, but it kind of depends on what your perspective is. And overall, a guy, Scott Becker, who's the CEO of the Association of Public Health Laboratory, which is kind of the number one organization for like new laboratory tests and how good are they. And he had a one-word description of what he thought of as the quality of COVID antibody tests. And that is the description. Another thing that I want you guys to know about antibodies is that they're not all the same. I'm not going to teach you every single type of antibody that's out there, but I want you to know the difference between two different ones, IgM and IgG. IgM and Ig stands for immunoglobulin. Immuno just means it's an immune type cell. It helps your immune system. And globulin is a fancy word for protein. So it's a protein that helps your immune system. And there are different reasons why this one is an M and this one is a G. But the bottom line is that IgMs are, they increase in your bloodstream and then they disappear while you are symptomatic. This blue line is you have the virus. The green line is your IgMs go up and down. But then what happens is your body produces something new, this IgG, and it only starts to get produced when everything else is going down, and then it remains in your blood and provides the long-term immunity. So the IgM is the short-term immunity, and the IgG is the long-term immunity. Well, I've looked up a lot of the tests, those 70 tests that they're creating, and in a lot of the documentation for the tests, they don't even say, is it looking for an IgM or an IgG? Because sometimes people produce IgMs, but they don't even produce the IgGs because their body doesn't mount a good enough immune response. And so we don't even necessarily know how to interpret the results of an antibody test. Does it mean that you are actively being infected with the critter, and so it's an IgM that they're finding? Or did you have it 3 weeks ago, or a month ago, or 2 months ago, and we're detecting IgG, and so now you've at least mounted an immune response, whether or not you actually are immune. So I just am trying to explain to you guys how you'll read articles about antibodies, about immunity, and how many questions there are. That being said, testing is definitely increasing in the United States, and this is only April, and it has kind of gone on since then. A lot of people are asking questions about testing, and testing in one way is extremely important. one of the things that you guys read, one of those articles said that, look, testing is extremely important, but it's just the beginning. We'll talk about this a little bit more, in just a few slides. However, I just want to also give you guys that grain of salt so that you can be a critical thinker when you are starting to read things related to testing. Here's an example of a study that everyone was very excited about, the ID Now, because it can produce results in less than 15 minutes. And that was a big problem. The early tests took days to come back. And so the person would have already, infected, maybe 20 people during that time. However, they talk here about they're concerned about false negatives, which we talked a little bit about. The other thing that you'll see related to this is, something like this. Here are projected deaths, right? And then here, this yellow line are the actual deaths. Wow, this is really interesting. Do you kind of see a pattern there? It's sort of an up and down. And look at that. The days, if you look at the days where there's the least disease, it was weekends. Wow, what is it about weekends that helps people not die from the coronavirus? Well, the answer is nothing. The answer is that on weekends, they weren't processing the death certificates. And so on Monday, they would process everything that happened over the weekend, and it would look like there was a big spike. So the bottom line is, this is yet another one of those ways that you need to take the data that you see with a grain of salt. This is just a complete artifact of when they process death data. Okay. One more critical issue related to false positives and testing. And again, I agree with public health advocates who say we need to have testing as a critical component of opening, because we need to know who is potentially infectious. I mean, imagine if, somehow magically, like we were all in a video game, people that were infected had sort of like a red bubble, kind of floating above their head, right? Then you could sort of like peek into a restaurant, see that there was no one there. You could just go eat and be totally comfortable. Or you could peek into, a big park where there's a bunch of people, see a few red balloons and be like, oh, I see where all the people are who are infected. I'm not going to go there. So you can see how the theory of testing is really, really outstanding. And one thing that, for example, we could do is if everybody comes back to campus in the fall, we could, try to get a grant from the state or the government or just something to test tens of thousands of people, to test all 28,000 students, all 40,000 people, in our community. Okay, but let's think about this a little bit. Let's say that there are 10,000 people. And let's say that 1% of them are actually infected with COVID. It's probably less than that, actually, because but let's just, for the sake of argument, let's just say we have some condition, maybe it's not even COVID we're talking about, but we're testing something where 1% of the people are going to have it, but we're going to test everybody. So we're going to know everybody who has it. Isn't this going to be great? And we're going to assume it's a really good test. It's only 5% false negatives. It's only 5% false positives. So it's sort of what you would say is like a 95% accurate test. Okay. What this means is that we have a total of 10,000 people. And we're going to have this column is the people who actually have, say, COVID, and the people who don't have COVID. And here we're going to see the people who test positive and the people who test negative. Okay. This should be pretty obvious to you. The number of people, if it's a 1% incidence, 10,000 people were tested, 100 of those people actually have COVID. Therefore, 9,900, just 10,000 minus 100 don't have COVID. Okay. So what this would mean is, because we know that this is a 95% accurate test, that of these 100 people, 95, okay, of these COVID positive people are going to test positive, right? We got it right 95% of the time, and 5% of the time we messed up. Okay, they had a positive test, but they actually had it, and the test was wrong only 5% of the time. Okay, so what about this column? Well, what this column looks like is this. Because what it means is there are 9,900 people who don't have COVID. It's a 95% accurate test. So what we do is we say that, this test, this negative, this person who doesn't have it, the test was accurate 95% of 9,900. And if you multiply 0.95 times 9,900, you get 9,405. 5% of 9,900 is 495 people. So these people are kind of unfortunate because they don't have COVID, but the test came back positive. So when we add up these numbers, how many people are going to test positive? Well, these 95 and these 495, so that's a total of 590. How many people are going to test negative? Well, these 5 people plus 9,410 or 9,405, so 9,410 people are going to test negative. But hold on a second. We just tested 10,000 people at the University of Arkansas, and 590 were positive. But only 95 of those people actually have it. 500 of those people, we told them, guess what? You have COVID. They freaked out. Their families freaked out. They got sent away. Everyone they know has been told, and they actually don't have it. Of the 590 who tested positive, only 95 out of 590, or 16%, actually have it. This is called the positive predictive value. And these numbers are really bad when you have a rare condition. And this would count as a rare condition. Now let's look at the negative predictive value. So if you have a test that's negative, like this 9410, how many of those were actually negative? Well, 9405, which is like 99.9%. So the negative predictive value of this test is 99.9%. But the positive predictive value of the test is 16%. And here, the positive predictive value is a real problem because you're testing 10,000 people, you're having all these false positives, and you are causing a lot of chaos in the community. What if it was only a 0.2% incidence, right? What if instead of 100 people actually having it out of the 10,000, only 20 people have it? Well, then these are the numbers. And look at this. Of the 513 people who tested positive, only 19 people have it, which is about 3.7%. Okay, so this is why testing is just the beginning of the battle against COVID-19. We need to think about what the tests mean. We need to figure out what to do with the tests once we have it. For example, once we have a positive test, do we retest? Well, maybe that test just got it wrong. So maybe we have to use a different test. But maybe they just didn't, maybe the test just got messed up or got switched or something. How do we control information? How do we keep people from freaking out and, especially when things are false positives? And then there's this whole idea that they talked about regarding contact tracing and just how critical this is in public health, that we need people to, find out, where has everybody been? Do we quarantine people? The testing, if you're negative, we also need to control information, because if we test 10,000 people, right, and all of these people end up with negative tests, 9,000 people with negative tests, are they all going to all of a sudden say, I'm immune, I don't have it? Are they going to not understand the information? And are they going to have very, very unhealthy behaviors that are going to lead to them then getting infected, then spreading that infection to grandma, and then having another big spike of this pandemic? So what you guys read about was, public health detectives and how they track these diseases. A couple people asked a really good question, which was, in this article, they talked about how 30,000, public health workers have been cut over the past, several years. Why is that? It's all political. It's all, people saying, well, you know what? We need more money in defense. We need more money in something else. And so people will say, let's cut money from public health, because what are those people doing anyway? So, because of this pandemic, maybe some of those will be brought back, but maybe not, we'll see. Interestingly, the people who do this kind of detective tracking is, generally they're tracking things like HIV, syphilis, gonorrhea, and chlamydia. These are all sexually transmitted diseases, right? So if you get a sexually transmitted disease, the assumption is that you're not going to pass that, a second later, right, by shaking somebody's hand. You're going to be passing that, the next time you have intercourse, which probably is not going to be within the next couple of hours. But the problem is that one person on the contract tracing squad who is used to doing this standard contract tracing for sexually transmitted diseases, they're calling 3 or 4 people a day. They're finding out all their partners. They're finding out where they've been. They can go into a lot of detail. They can make trees and find out exactly who to contact, et cetera, et cetera. But we do not have this luxury with COVID, because if we find out that there is a positive case in the community, that person on average will, be the R naught, they'll be infecting, between 3 and 5 people immediately. Those people will be infecting 3 to 5 people. Those people will be infecting 3 to 5 people. And all of a sudden you've got a real tree. One thing that's kind of interesting is people are saying, well, maybe we can do contact tracing through our, networks, who knows? Okay. Speaking of networks, let's talk a little bit about information, panic, and COVID. A lot of what we're hearing about these days is this idea of an infodemic. So here's this idea that, a Yale expert offers strategies on how to interrupt this daily flow of information, some of which may be accurate, some is not accurate, and even when it is accurate, can be a problem. So let's take the example of 9/11. One of the most tragic things that has happened on U.S. soil in my lifetime. There was a study done about a year after 9/11 that was published in the Journal of the American Medical Association. And what they did here was they looked for post-traumatic stress disorder. They surveyed people from all over the United States. Some people in New York City, some people in DC, where there was actual damage. Some people from other metropolitan areas, some people in other parts of the United States. They sampled people, 270 of the people actually had family, friends, or coworkers injured or killed. And some people had loved ones in the military. And then they also measured how much television these people watched. So look at some of the results. Some of the results is that if you actually had family, friends, or coworker injured or killed, your likelihood of having post-traumatic stress disorder was 13.2%. So, and that was a lot higher than the 3.9% that people who did not have family, friends, or coworkers injured or killed, right? And that makes sense. If you had somebody close to you actually die or get injured, there was a 4 times the likelihood that you were going to be, that you were going to feel that PTSD yourself, like you were actually there. But look at the television numbers. People that watched more than 12 hours of television per day were more than 10 times as likely than people who watched less than 4 hours per day to have post-traumatic stress disorder. Even though those people who were watching television, they might have been living in Iowa. They might have been living, completely, away from where the actual event was. And that was the strongest p-value in the entire study. And you can see the strength of that relationship, that the more television you watch was actually as powerful as, actually knowing people or actually being there, actually living in New York City, as opposed to, living in the rest of the United States. There, that was 3 times as much. This was 10 times as much or 12 times as much. So the bottom line is that these days, being addicted to the news, being addicted to social media can actually give you the same disease. It can actually make you feel like you're there. A lot of people are suffering with COVID, but guess what? The 99 point whatever percent of people who are not personally suffering with COVID, when they are consuming all of the media that is telling them about all of the horrible things that are happening, they are also sort of suffering with COVID. Now, it becomes very tricky because we don't know then what to do, because we do need information. It's not good to just sort of hide and pretend that it's not existing. But we also need to understand this kind of study and realize that these days, what you see in the media can be as real as the real thing. Here's another example of a study. This is one of our studies, and we looked at just social media exposure overall. So quartile 4 are the people with the most social media exposure. Quartile 1 are people who almost never use social media. And then up on the y-axis, we're going to see the likelihood of depression. And what we found is that people who use the most social media, even when you control for 17 variables, are 3 times as likely to be depressed. We found in a follow-up study that they're also 3 or 3.5 times as likely to feel more isolated, right? Which is weird because social media is supposed to make you feel connected to everybody, right? Well, sometimes we probably do feel connected to people as we're, using Zoom and, House Party and all kinds of other things to connect with each other. But, there's also this weird sort of counterintuitive thing going on that sometimes we go onto a social network site and we kind of feel like everybody else is more connected. Everybody else has it all together. Everybody else has a better life than I do. The other thing that we showed is that for every positive experience, your odds ratio for depression goes up significantly, about 15%. But for the same dose of a positive, that's for a negative experience. For every negative, sort of dose of negative experience, your odds of depression go up 15%. But for every dose of positive experience, your odds of depression only go down about 5%. So what this shows is that negative information on social media seems to be sort of more powerful. I mean, if somehow we could only have positive experiences on social media, if it was only puppies, if it was only, adorable babies that we were liking, and we never had jealousy, and we never had, saw, things that made us anxious and panicked and afraid, then yeah, maybe social media use would actually lower our risk of depression. But unfortunately, this is what we're seeing a lot more these days. And then, of course, there's all the misinformation. I don't know how many people have heard about 5G cell towers. Wiz Khalifa tweeted, Woody Harrelson tweeted that they think that it's the 5G cell towers that have made COVID so bad. There have been arson attacks against these towers, but over and over again, it's been proved scientifically that radio waves just cannot influence viruses. But, these tweets are retweeted, and, this is part of that infodemic that makes, people, whether the information is accurate, it can be a problem, or whether the information is inaccurate, it can be a problem. There's also this issue of that some people say another big conspiracy theory is that COVID is a conspiracy to vaccinate us all. So rapper MIA said in a tweet, if I have to choose the vaccine or chip, I'm going to choose death. What does this chip thing mean? Well, in anti-vaccination circles, what people are saying is that this is a way that they're going to vaccinate us all, and they're going to secretly implant chips into all of our bodies so that they can follow us around. And so it is a concern about implanting everyone with a microchip. This anti-vaccination community has specifically targeted Bill Gates, who in the past has warned of a pandemic. So there's a lot of very strange information out there. This, for those of you who don't know, this anti-vaccination craze is very, very problematic. Measles cases in the United States are the highest since measles was eliminated in 2000. And a lot of this is deeply and it's generally misinformation that is being spread around about the vaccine causing things like autism, which has been shown over and over again to not be the case. Measles is a real problem. The R0 is sort of a public health measure of how infectious something is, and you can see that COVID is bad. It's between 2 and 6, right? It's which is a little more than the common cold in terms of infectivity. But look at measles, and look at what measles actually does to kids. I mean, people forgot about this. And before the vaccine was licensed in the mid 1960s, this is the number of cases. This is 500,000 cases per year. 500,000 kids would have this, and many would die from this. And then it also caused a lot of other complications, including deafness and inability to have children, et cetera, et cetera. And you can see that in 1990, here it just looks like a little blip because of the comparison with how much measles there was before the vaccine basically eliminated it. But this was because Star come out and say, oh, I'm not going to vaccinate my autism. There out there about the escaped or created this weapon. Fully, according to one study, 23% of people surveyed in the United States believe that it was created in China.
You're breaking up a little, Brian.
Sorry?
Oh, I was just the audio was breaking up a little bit there. But...
Oh, okay. Is it okay now?
Yep.
Okay, great. So 23% of people believe that the vaccine was created in a Chinese laboratory as a bioweapon. About 6% believe that, well, maybe it wasn't created on purpose, but it was accidentally released from a lab. Now, interestingly, there is a lab in Wuhan where they do vaccine research. And so it is, a concern. However, DNA sequencing proved that the virus that we see is now completely different. One last conspiracy theory I need to tell you about is this individual who has been responsible for convincing a lot of people that death rates are being inflated or fabricated. Unfortunately, she is a physician. She wore a white coat and gave a presentation that has been retweeted millions of times. And she's comparing here in this sign lockdown orders to Nazi rule. She turns out to be a very, very fringe anti-government and anti-vaccination proponent, and has been fueling protests and disregard for protective guidelines. These kind of things happen all the time. So what do we do about this? Well, to minimize this infodemic overload that we have, the World Health Organization, for example, says, well, you should try to minimize what you actually see in the news. I mean, yeah, it may be important to, to keep up to date somewhat, but that doesn't mean that you need to be looking every minute, every hour, every even day at, numbers, because a lot of the problems that cause you to feel anxious or distressed might be actually more problematic than, the condition in certain ways. You should also seek information, of course, from trusted sources so that you can take practical steps. Look for updates at specific times. They're saying here maybe once or twice a day. Avoid getting caught up in sudden and near constant stream of reports. But the problem is that today, those reports are everywhere. If we do any kind of a search, on Google, we're going to see up-to-date numbers that change every minute. And there are people with true problems that are addicted to things that change numerically, like stock market reports and things like that. And so this kind of thing is going to be very, very difficult to deal with. Okay, so how do we wrap this up? Well, we started with saying, look, how many deaths are there going to be? Well, we don't know. Maybe between 500 and a million, even if we're being, kind of on the outside end. I mean, so far we're at about 250. They're estimating between 570, 700,000, worldwide, but maybe it'll be as many as a million. But, will there be lives saved from reduced pollution? Again, this is not, to say that there's anything good about this pandemic, but it is just to say that this is how public health people have to think. But on the other hand, how many deaths are there going to be from anxiety and depression and economic crisis and social isolation based on the different studies that we looked at related to that? And even if it doesn't actually cause deaths, what about morbidity? What about just increased disability? People who can't function as well, despair, people who are going to carry, the trauma of this potentially for the rest of their lives. We talked about car accidents. Are 100,000 to 300,000 lives going to be saved from fewer car accidents? Are there going to be more suicides? There already have been. Are there going to be fewer murders because people are just not, out as much? Is there going to be more domestic violence because people are going to be in more? Are there going to be fewer school shootings? Well, guess what? March 2020 was the first March in the last 18 years that there has not been a school shooting in the United States of America. So the bottom line is all of these things are concerns all the time. I mean, COVID is a big deal public health wise, but public health people are thinking about this stuff all the time. They're thinking about this stuff all the time. And I didn't even put on here the tobacco deaths because that is a little bit more speculative. There haven't been a whole lot of studies. But again, if tobacco deaths increase even just 4% worldwide, that is an additional 200,000 people because on that 5 million. If they increase 8%, that's 400,000 deaths. And those people may stay addicted to cigarettes for the next 20 years, not just, for the next year. We talked about diet and activity patterns. The bottom line is that when it all comes down to it, we can look at all these numbers, we can think about all the issues, but we just don't know how many deaths there are going to be. We just don't know exactly how many people are going to be impacted and what ways. I hope that many of you decide to go into public health for some reason to see what these sheer numbers are and to see how this crisis, it just really magnifies how important public health is as a discipline, because we're thinking about these things whether there's a pandemic or not, because there are other pandemics of tobacco use, of pollution, of depression, anxiety, isolation, and suicidality. And we need to have a global response to all of these things if we're truly thinking about things in a public health way. Thank you very much. And I tried to integrate your questions into the presentation. You guys had great questions, but what I did was I tried to integrate them throughout instead of addressing them afterwards. And so it looks like I am 4 minutes early. Is that okay, Dean Kuhn?
That's great. Thank you so much. That was, wow. I will say first, disturbing. Man, that ending was